Adventurer, husband, father, cancer survivor, and now emergency heart surgery. We share one patient's bold choice to fly across the country from Alaska to Kansas City for his urgent open heart surgery here at the University of Kansas Health System. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. When Bart Rudolph was told he needed open heart surgery and fast, the simplest choice would have been to have it in Alaska, where he lives near his home. Instead, he chose to fly across the country with what was described as a ticking time bomb in his chest. And that's because he wanted to be at the same place that saved his life when he had cancer decades earlier.
So now I start.
Walking the indoor track at cardiac rehab and exercising on the treadmill are far cries from the kinds of activities Bart Rudolph is used to. All right. But he's in much better condition than when he arrived in Kansas City from Alaska 5 weeks ago.
I feel great, leaps and bounds from where I started from.
The 44-year-old moved to Alaska from Kansas City 15 years ago, and he loves everything about the adventurous life he's built up there.
I've ridden to a glacier, I've ridden on a glacier.
That life includes his wife, his 2-year-old son, and another baby on the way.
We're outside every day, rain, shine, snow, -10.
But 5 weeks ago, his beautiful life was in jeopardy.
I had an angiogram in Anchorage, and that revealed a clogged artery at like 95% on an artery that they call the widow's maker.
The trouble actually began decades ago when Bart had cancer. It was the team at the University of Kansas Cancer Center that saved his life. But he knew the radiation treatments he received could one day affect his heart.
Radiation that I had about 20 years ago for cancer most likely calcified some arteries without really knowing it.
Bart already needed one of his heart valves replaced. That was not an emergency situation, but this?
It was kind of like a ticking time bomb.
He needed bypass surgery. He immediately called the University of Kansas Health System for a second opinion and spoke to cardiothoracic surgeon Dr. Omar Almagrabi.
When he called me and said, "You need to do this immediately."
Dr. Almagrabi said he could replace Bart's heart valve and do bypass surgery all at once, but it was flying to Kansas City from Alaska he did not recommend. Bart didn't care. He wanted to be at the same place that saved his life once before.
Probably like an hour and a half after he called me, booked a flight, came here, got admitted into KU, and had the surgery the next day.
After the surgery and then weeks of cardiac rehab, Bart is finally headed home.
I fly back tomorrow.
With a heart filled with gratitude for Dr. Almagrabi and his team.
Just want to say thank you. He essentially saved my life. Thanks for everything. You've been great. Yes. Bye.
We are so happy to have Bart joining us virtually from his home in Alaska. Good morning, Bart.
Good morning.
How are you feeling today?
I feel good. I feel a lot better, making progress every day still.
And what time is it in Alaska, by the way?
It's 5 a.m.
Thank you for waking up and doing this. We appreciate it. We're going to get to these two brilliant doctors in a moment. But first, I do want to talk to you a little bit more about all the pictures you have shared with us of your life in Alaska. It looks like so much fun. What was the first fun outdoorsy thing you did, Bart, when you got back home?
Well, it wasn't so crazy. It was really just walking to the park with my son and going sledding. And since then, we're doing some fat tire bike riding in the snow, but working my way back up to some of those more crazy adventures.
I feel like a very sheltered Midwestern person by saying I'd never heard of fat tire biking. For the audience, can you explain what that is? Because you mentioned that a couple times.
Yeah, it's basically a bike with a 5-inch wide tire, and it has little studs on it so you don't slip on the ice, but it is made to ride on the snow or in sand, but up here, obviously, we use it on snow, and we bike year-round.
Okay, now that we've got that established, thank you, Bart. And this really illustrates, this is not a guy that likes to stand still or lay down or be stopped from his stuff, which is where the doctors come into play. I'd love to welcome Bart's cardiothoracic surgeon to the program, Dr. Omar Almagrabi. Thank you for being here.
Absolutely. Thank you for having me. And Bart, good to see you.
Good to see you.
Glad you're doing well.
And we're also very happy to welcome cardio-oncologist Dr. Hamed Dakordi. Dr. Dakordi, as a cardio-oncologist, you specialize in treating or preventing heart problems that can come from cancer treatments, which is likely what happened to Bart. We'll get to your specialty in a moment, but first the surgery. So Dr. Almagrabi, you advised Bart absolutely against getting on a plane and flying.
Right. So I guess it goes back to about a year ago. We met for the first time in regards to his aortic valve, and it was stenotic, meaning it wasn't fully opening. It was calcified, and part of the workup included a left heart catheterization to look at his blood vessels because he was at an increased risk of coronary artery disease. And a few months later, he gets the heart cath done, and I reviewed the images, and I saw the left anterior descending artery, which is the widowmaker, at a 95% blockage. So I called him immediately, and we talked, and he was, he told me that he was having some lightheadedness, and I believe maybe even a syncopal episode, but I can't remember. But
what's a syncopal episode?
Where he loses a consciousness.
Oh, gosh.
And so he was having symptoms with this 95% blockage. So I got worried, and I gave him my phone number, and we start texting, and I told him, you need to go to the nearest hospital. You have unstable angina. Well, he was he did not agree with that, and he wanted to fly to Kansas. And I even actually reached out to a few people that I know in Alaska where he lived, and found him a surgeon and a hospital, and I made that recommendation to him. But his response was, "I'll be there tonight."
Oh my gosh. Okay, you're smiling now because it worked out.
Yeah.
Were you sweating at the time?
Well, talk about patient-induced heart attack, but I was worried about him, honestly, and that's why I gave him my phone number. I told him to stay in touch, let me know what's going on at all times. And when he arrived, I found out he was in the emergency room immediately because I had notified my team to let me know as soon as he arrived.
Bart, question for all the wives out there: how did that conversation go with your wife?
Well, it happened so very fast, but she was in the room with me when Dr. Almagrabi called. And so immediately we got off the phone and we had to make a quick decision. And I had already decided to have my surgery in Kansas, and it just made sense because I have family there. I could recover. Her mom was going to come up here and help with the baby. It was all worked out. It was just, now we had to make a quick decision. So together,
She was okay with you flying?
She was nervous, definitely nervous, and wish that she could have come along with me, but we both decided that I should go.
Well, thank goodness it worked out. It worked out. You arrived here to the pros. Let's take a look at some of the images that Dr. Almagrabi shared with us to show what was happening inside Bart's chest. This first image, Bart had a 95% blockage. Is it visible in this scan?
Yeah, if you look at the red arrow, it's pointing towards that narrowing of the blood vessel. You can see before and after that blood vessel, or before that arrow, you can see how wide that artery is, and then it narrows, and then it widens again. So that is a blockage.
That's the widowmaker?
That is the left anterior descending artery, also known as the widowmaker.
And why is it called the widowmaker?
So the left anterior descending artery supplies the left ventricle, which is the main pump of the heart. And when it goes down and it's completely blocked, you lose pretty much all of your cardiac output, and people drop dead. So that's the biggest concern about it. That's why they call it the widowmaker.
Is it mostly men that get this?
It can happen in both.
Yeah.
Men at a little higher risk, but it happens in anybody.
Okay. Bart, you also needed a valve replacement. So, Dr. Almagrabi, how does the combination of needing a valve replacement make this more complex for you as a surgeon dealing with both? Right.
In the general population, this is excluding anyone who's had radiation, the risks are much more elevated because the operative time doubles, the risks are much more increased. So you go from a mortality risk maybe of 1% to about 3 to 4%. So certainly the comorbidities also increase. And then in the setting of chest radiation, there are other things that we worry about, which will also elevate that risk as well.
When it comes to this next image that you shared with us, what is this and why is that part circled?
So here, this is a CT scan of his chest, axial view, and we're looking at...
Like from, what does axial view mean to non-medical audience?
Right, so the top would be basically his chest. The bottom part of the image is his back.
His
and
spine is at the bottom, okay.
Yeah, spine is at the bottom.
Slice.
And the screen right is actually kind of flipped. The left side of his body, screen left is the right side of his body. And we're doing kind of cross-sectional images. So we're looking, technically, if you think about it, from the feet up. So we're looking at that cross-section. And what you see is the blood vessels, but what I'm circling here is his mediastinum. And typically, in anyone who's had chest radiation, we would like to get some imaging to see if there were any scarring, any fibrosis from the radiation itself. We also look at the blood vessels to look for any calcification. We also assess the lung field itself, see if there's any parenchymal damage or tissue damage to the lungs itself from radiation. Here you can see a little bit of scarring, but nothing significant.
Dr. DeCourty, I want to bring you in as the cardio-oncologist. Is that image, if we can keep that image up for a second, I want to ask you, is that what kinds of images do you normally request, and does that look familiar to you as your specialty?
Absolutely. One of the aspects of the radiation-induced cardiotoxicity, as we talked about, is damage to the different structures of the heart, and including vessels, both large blood vessels as well as coronary artery. One of the tools that we have to assess the degree and the extent of the damage is chest X-ray. We do this, for example, in the case of coronary artery disease in the form of a calcium score, where we quantify the amount of calcium or calcification that we have in the coronary arteries, and this is one tool among the other things that we do to evaluate patients who has history of radiation for evidence of radiation-induced heart disease.
We also have an echocardiogram to show our viewers. When did you take this echocardiogram of Bart?
I believe the first time we met, he had already done this echo, and we're looking at the aortic valve, and you can see how calcified it is. That chunk of calcium, that bright color that is moving right there, that is the aortic valve attempting to open. And here's another cross-section view of that valve where there's color flow going through it. But it shouldn't be that bright. The leaflet should be more, darker. But in his situation, you can see that it's trying to move, trying to open up, and very, very bright in color, telling us that there is certain, amount of calcification there.
There's a problem. And finally, we have one more viewer. One of the things that's fascinating about looking at these and then asking the doctors is that to us, it's like a Rorschach test. By us, I mean me, because without a medical degree, I would not know what this shows to me. But what is this? This is a pericardium. First, what's a pericardium?
So the pericardium is the sac that houses the heart. It has a smooth surface. It's very flexible, allows the heart to beat within it without friction, allows the heart to move and expand and recoil without any constriction.
And what stands out to you about his pericardium here?
That's part of the assessment as well in someone who's had chest radiation. We look at that pericardium and see how thickened it is. You can tell there's a degree of thickening there, but nothing too significant. However, it doesn't really tell you much. You have to get in there and figure it out yourself. But sometimes you're able to see it when it's really calcified and thickened. In his case, it wasn't too bad.
Dr. DeCourty, our cardio-oncologist here, you didn't treat Bart, but this is your expertise. This is your life's work. What is the radiation doing to Bart's heart to cause the problems?
Well, what I'm seeing here is a kind of a classic presentation of different components of radiation-induced heart disease. The radiation-induced heart disease is a constellation of damages which happen because of the radiation to different parts of the heart. Starting with the pericardium, the sac surrounding the heart, we already see evidence of pericardial thickening, which in cases, if it becomes severe enough, it could be constrictive, and it could constrict the heart and causing a condition called constrictive pericarditis. Another aspect of the radiation-induced heart disease is the valve, the disease that it can cause to the valves, which we already see in Bart affecting the aortic valve, which is actually the most common valve affected by radiation-induced heart disease. It can also affect the cardiac muscle itself and the vessels. Again, in case of Bart, we see evidence of coronary artery disease, very likely exacerbated by the history of the radiation. Fortunately, there is no indication based on the echocardiogram that the muscle of the heart is affected. The squeezing function appears to be preserved. However, in long term, we can see myocardial fibrosis and we can see damage to the heart muscle, particularly when the radiation is combined with sort of cardiotoxic chemotherapy, which Bart actually received during his chemotherapy for lymphoma.
Bart, as we look at these images of another patient undergoing radiation, can you tell us what kind of cancer did you survive? Where was it?
I had lymphoma in the throat and upper chest.
Okay. And how long did you get radiation treatment? And you also received chemo, is that correct?
Yeah, I did intense chemo for 6 months and then like maintenance chemo, I think for an additional year. And then I did radiation for, I think 6 weeks. It was about 20 years ago, so I'm trying to remember.
20 years ago. So you were really young when you were diagnosed with cancer. You were a teenager.
Yeah, I was in college.
In college, okay. So Dr. DeCordy, at what point of cancer treatment does this start to affect Bart's heart? Is there any way of telling when this started developing?
So Bart is actually at the kind of the peak time frame as we're talking about the risk of radiation-induced cardiotoxicity. He's at the peak at about 2 decades after his radiation exposure. However, some of the downstream effects of radiation on the heart can happen within a matter of days or weeks. For example, radiation, particularly intense radiation involving the pericardium, can lead to acute inflammation of the pericardium or acute pericarditis. This can present itself very early on. However, other aspects of cardiotoxicity, for example, damage to the coronary arteries, generally takes somewhere between 5 to 10 years to start to show themselves. It can happen as early as 2 or 3 years, depending on the degree and the extent of irradiation, and also depending on the underlying traditional risk factors that a patient has. For example, things such as sedentary lifestyle, diabetes, hypertension, these will affect the time frame as well.
There are cancer patients watching, people with loved ones who are undergoing that, people who've completed cancer treatment years ago. So for those viewers, what scans or tests should they request and when to see if they have a problem brewing like Bart's?
So cardio-oncology involves evaluating and assessing patients sometime even before initiation of cancer treatment, depending on the risk that they have. A lot of times we support the patient throughout their cancer treatment because they sometimes have difficulties with the cardiovascular system because of the cancer therapy. And then as part of the survivorship program, we can continue to follow patients for decades. Now, there is not a single scan that we specifically use for this purpose. Depending on the structures that can be affected, we use different scans. For example, you mentioned echocardiogram.
Right.
Echocardiogram is kind of a workhorse for us evaluating the valvular structures and the myocardium, the muscle of the heart. And this is something that we generally do quite early after radiation and cardiotoxic cancer treatment, and we'll usually repeat that on annual or every 2 to 5 years, depending on the risk. And I was going to actually ask Bart if he has a cardio-oncologist in Alaska already.
I do not, no.
Okay.
You don't.
You definitely should establish care with a cardio-oncologist who probably see them at least once a year to continuously monitor you for all the other potential side effects that can happen because of the prior history of cancer treatment.
Bart, would you know who to call to establish that care, or do you need us to connect you with the two experts, your surgeon and our cardio-oncologist here afterwards, after the show?
No, I see a cardiologist at the Heart Institute here that has a ton of doctors, so I'm sure there's probably somebody there.
So he just asks his doctor there.
That's correct.
What to do.
Yeah.
So glad that you told Bart that, because you haven't seen a cardio-oncologist since you got home. Does that make you nervous?
Correct, yeah.
Dr. Al-Maghrabi? I mean, this guy has made you nervous more than once.
I'm used to it by now, yeah.
We have some really good questions coming in and some comments. So if you have a question or a comment that you would like us to read out loud on the program, you can send it to us on YouTube, Facebook, or the All Things Heart email. You'll find all the links on your screen right now. Bart, how soon after your surgery were you sent to cardiac rehab?
I think it was just a few weeks after surgery.
Which activities were hardest for you, and how weird was it to find activities like gentle walking difficult, being as active as you normally are?
Yeah, the walking was the hardest part. It was walking up a slight hill in the neighborhood. Was surprisingly very difficult, but the thing that was hardest to get over was I couldn't pick up my son. I had a weight limit restriction, so not being able to lift anything was really difficult.
What kinds of activities did you do in cardiac rehab that you felt really propelled your recovery forward?
Weightlifting and the treadmill and the bicycle is what I did mostly.
As a guy that's used to pushing his limits, what are some of the things that you're still looking forward to doing that are in future goals that you haven't been able to get to yet?
Oh man, I'm looking forward to going on some multi-day bike rides through the mountains or some long hikes without getting really winded.
Now, do you do all these things as a family? I know your child is little. Are you one of those guys that puts them on your back and still hikes like 100 miles?
Oh yeah, absolutely. We do everything together, and we're outside almost every day.
What a cool family. We have some community questions that I want to get to. Let's get to Jack's question. Jack wants to know, how do you measure success in cardiac rehab, and is it necessary with every heart surgery patient?
Good question. So cardiac rehab is a medically structured program. It typically consists of 36 sessions that are covered by insurance. And the reason why it's covered, because we do have data to show that people that go to cardiac rehab after heart surgery do much better from a mortality risk standpoint. You learn how to exercise, your vital signs are being monitored while exercising. They go over nutrition, medication, and overall wellness. You get to see other patients who have gone through similar experiences and get to compete and kind of talk and share some of those experiences as well. So overall, there's plenty of data to show how successful it is.
Janet wants to know, Dr. Al-Maghrabi, did the radiation exposure Bart had years ago change the way you operated on his heart?
Absolutely, and I believe Bart may remember some of the conversations we had, and that's the reason why we got an echo, got a CT scan, to look for the aorta, to look for any mediastinal fibrosis or scarring. But what we heard earlier, when we look at the echo, we look at the heart function, is it preserved, and then also we look at the diastolic function of the heart and see if it's very stiff or not. Now, even though his heart was fine on echo, when we go on heart-lung bypass machine or the cardiopulmonary bypass machine, there's always a concern that we may not be able to separate from it right away, and it might be a little bit challenging to separate from, just given the amount of diastolic dysfunction within the heart and the fibrosis within the heart. So that's another thing that we think about. Even if all the scans are normal, there's a lot of uncertainty once we get in. Also, opening up the pericardium, looking for the major structures. sometimes everything is pretty scarred, and they call it a hostile chest, where you get in and everything feels woody and fibrotic, and it makes the surgery a lot more difficult and longer, obviously, until you identify all the structures.
Was Bart's a hostile chest?
It was not. It was not hostile, actually. He did us a favor.
Yeah, the one favor, the one thing that didn't make you sweat as his doctor.
Right, but we were prepared for it, and that's kind of, you know, the conversation we had about he may need to be in the ICU a little bit longer than the average person. He might need more support than somebody else.
When you're working with a cardio-oncologist, this is a me question, like Dr. DeCourty, do you have Dr. DeCourty in the surgery room with you while you're doing these things, or are you having separate meetings weekly? What does that look like?
He is more than welcome to come join us at any time.
But he's not usually
it's an open invitation, but no, usually he's in his office, in his clinic, and saving lives in other aspects in different ways. But yeah, we communicate quite a bit.
At what point do you refer? Who refers who to who? Do you refer your patients to Dr. Al-Maghrabi, or do you find that you're looking at your patients and saying, oh my goodness, you need to see Dr. DeCourty?
So in a perfect world, I should be the one following the patient after having a high-risk radiation, and eventually the development of coronary artery disease or a calcific valve disease, then I should be the one referring the patient to a surgeon like Dr. Al-Maghrabi for evaluation and treatment. But well, it doesn't necessarily go like that all the time. Sometimes it goes the other way. We find the valve disease and we treat the valve disease, and then we establish care for ongoing survivorship and follow-up.
And this was that reversal where he sees you first, and then thank goodness DeCourty swoops in and says, hey, you've got to make an appointment with a cardio-oncologist.
Right.
Alice has a comment. Alice writes, I can't think of a worse name for a problem than Widowmaker. I mean, that's true. That's a pretty grim name. How does someone know if they have a blockage like that? What are the typical symptoms?
Symptoms of myocardial infarction or heart attack. Pretty much chest pressure, crushing pain, pain radiating to the jaw, to the left arm. And now in females, it could be a little bit atypical, where usually they present with nausea, vomiting, abdominal pain, discomfort. So just pretty much the symptoms of heart attack.
Question for Dr. DeCourty, and this one is from Becca. She wants to know, should every single patient undergoing a cancer treatment ask for a cardio-oncologist?
Well, I encourage every person who is undergoing cancer treatment to discuss their cardiovascular health with their oncologist. But what the oncology team generally do is, depending on the type of cancer and depending on the type of treatment that the patient has to receive, and again, depending on the type of risk factors that any particular patient has, they do what we call a risk stratification. They determine what are the risks for every specific patient, and those patients who are at higher risk, those are the ones who get referred to cardio-oncology even before treatment for cancer starts. But like what I said, discussing the cardiovascular health with your oncologist is a very, very good strategy.
As we wrap up this discussion, Bart, I want to ask you, what would be your message to the viewers watching or to your doctors?
To the viewers going through anything, just staying positive. I think that has the biggest outcome of everything. And then to the doctors and Dr. Al-Maghrabi and everyone, just a big thank you, because I really do think you saved my life. I chose to go to KU because of Dr. Al-Maghrabi, and he's incredibly confident and competent, and explained to me some things that I had not heard from Alaska doctors, and just made me feel really good about my decision of going there. So I just want to really thank him for everything that he's done.
Dr. Al-Maghrabi, that must feel so great.
Absolutely, absolutely. No, I'm so glad that you're doing well, and I'm glad that we had the opportunity to take care of you here at KU. I mean, my advice to everybody who's, you know, if you've ever had any chest radiation, whether it's mantle, which is a technology of the past, or more focused radiation, you should definitely establish care with a cardio-oncologist. And if you were to undergo surgery, make sure that your surgeon is aware of that.
Dr. DeCourty, what would you like our viewers to know?
My kind of 2 cents for the viewers is it is true that the current cancer treatments do magic, really. They save life. But sometimes some cancer treatments come with cardiovascular risk. And we are here. We are here to help you navigate those risks. We are here to hopefully optimize the general cardiovascular risk for cancer survivors and patients who are all undergoing treatment for a better outcome, for a better holistic result. The cardiovascular disease is actually the most common cause of morbidity and mortality in cancer survivors. So we need to take it very seriously.
Thank you for being here. And
Thank
Dr.
you for having
Almadavi,
us.
thank you so much for
Absolutely.
being here. It's a pleasure to have you both on. Bart, thanks for sharing your journey. You're going to help a lot of people. And call the cardio-oncologist today. I'm speaking for your mom. Call the cardio-oncologist. And to our viewers, if you'd like to watch or share any one of our previous episodes, just scan the QR code on the screen. It will take you to links of all of our past episodes. Coming up tomorrow, it's almost Valentine's Day, so tomorrow we're talking about how love or heartache can affect your actual heart health. That's at 8 a.m.